family on the app. She then syncs the data as and when she receives network connectivity. The syncing process enables the A&M to log into her application and access an automatically generated list of newly identified pregnant women in her catchment area. When the A&M plans for a next MCHN session, this due list of expected beneficiaries helps her in reviewing their histories and preparing ahead. To ensure maximum attendance, the Khushi Baby system also sends timely reminders to young mothers and pregnant women on their mobile phones about the upcoming MCHN session in the local dialect. On the session day, when the A&M enters fresh data into the application after examination, the app is able to provide a checkup summary and flag high-risk conditions based on the current health indicators of the beneficiary, nudging the A&M to refer such patients to the next level of care, that is, the primary or community health center in the area. The A&M is also able to view on our app due vaccines and the growth chart of children brought to the camp. This digital solution has replaced the legacy system of collecting, maintaining and transferring of paper records and reports, saving precious time and hassle to both the ASHA and the A&M. This allows the A&M to maximize. In this hilly terrain of Jharol block in the Udaipur district of Rajasthan, Ashas, the designated community health workers, go door to door, conducting the household survey, traversing the challenging topography in the sweltering heat. Tasked with promoting the health of the village, Ashas implement all major primary healthcare programs under Government of India's National Health Mission, including maternal, child and adolescent health programs and disease control programs for both communicable and non-communicable diseases. These women in blue act as the public health system's first level of curative care providers for a rural population of 1,000 people or thereabouts. Supported by 2 to 3 Ashas and providing the next level of care at the health sub-center to a population of nearly 3 to 5,000 villagers is the Auxiliary Nurse Midwife or A&M. The A&M conducts outreach sessions, health camps and provides services related to maternal and child health, family welfare, nutrition, immunization and other healthcare programs under the National Health Mission. It's at this last mile that Khushi Baby is strengthening the healthcare delivery system by digitally empowering the frontline health workers, the Ashas and the A&Ms. At this health sub-center in the Bedanpara village of Jharol block, Jyoti Dama, the local A&M, is conducting her weekly MCHN day. Every Thursday, like all A&Ms in the state, Jyoti conducts the physical examination of pregnant women and also checks their hemoglobin, blood pressure and sugar. Jyoti also measures the height, weight and other health indicators of infants and administers them vaccines. Newly pregnant Mahima Prasad is getting her first examination at the MCHN day. Jyoti creates a physical health record for Mahima called the Mamta card. However, unlike before, Jyoti also has the Khushi Baby A&M app. She saves Mahima's medical data in her mobile application and then pastes an NFC chip on Mahima's medical card. Then, through a simple scan of her smartphone, Jyoti stores Mahima's medical records in the NFC chip. Now, as Mahima progresses in her journey of care from family planning to pregnancy to delivery to postpartum care and childcare, Jyoti will be able to follow along with her mobile device. Unlike other mobile health applications, this ensures that Mahima's medical records are digitally accessible offline, regardless of the geographical location and network connectivity. Meaning that if Mahima visits her mother and goes to that village's sub-center for the next MCHN session, the A&M there can simply scan the NFC chip on Mahima's Mamta card to access her medical history and provide accurate care, thereby decentralizing Mahima's data. However, young women like Mahima are first enrolled into the Khushi baby system by ASHA workers much before they become pregnant. ASHA workers conduct a monthly door-to-door survey wherein they register the details of all members of a family on the offline ASHA digital health app developed by Khushi Baby. The ASHA also identifies eligible couples between the ages of 15 to 49 in that family and highlights any pregnant women in that family on the app. She then syncs the data as and when she receives network connectivity. The syncing process enables the A&M to log into her application and access an automatically generated list of newly identified pregnant women in her catchment area. When the A&M plans for a next MCHN session, this due list of expected beneficiaries helps her in reviewing their histories and preparing ahead. To ensure maximum attendance, the Khushi Baby system also sends timely reminders to young mothers and pregnant women on their mobile phones about the upcoming MCHN session in the local dialect. On the session day, when the A&M enters fresh data into the application after examination, the app is able to provide a checkup summary and flag high-risk conditions based on the current health indicators of the beneficiary, nudging the A&M to refer such patients to the next level of care, that is, the primary or community health center in the area. A&M is also able to view on our app due vaccines and the growth chart of children brought to the camp. This digital solution has replaced the legacy system of collecting, maintaining and transferring of paper records and reports, saving precious time and hassle to both the ASHA and the A&M. This allows the A&M to maximize her time at the sub-center in following up and delivering appropriate care to her highest risk patients. Here again, the Khushi Baby call center provides timely reminders to these high-risk patients on their pending visit to the PHC or CHC through personalized calls.
जी नमस्ते मैम, मैं निरोगी राजस्थान से बात कर रही हूँ मैम। मैडम, मैं आपसे ये जानना चाह रही थी कि जैसा कि अभी देखा गया है, आप अभी ANC कराने गए थे MCHN सत्र पे, है ना? तो उसके आधार पे जो रिपोर्ट आई है उसमें आपका जो खून की जांच हुई है आपकी, उसमें बहुत कम आया है।
When these anemic mothers or malnourished children visit the CHC, the MOIC or the medical officer in charge at the CHC is able to log in to her Khushi Baby mobile application and access the complete medical history of the visiting patient. For example, the MOIC is able to see in her mobile application how a high-risk pregnancy of a patient has progressed and provide adequate treatment based on that data. Once the MOIC updates this patient's data in a mobile application, the A&M and the ASHA are automatically notified in their respective applications. This longitudinal sharing of medical data between the three key workers of the public health system, the ASHA, the A&M and the MOIC, is enabling better health outcomes for the rural population. Finally, the data from all these three levels is integrated into the Community Health Integrated Platform or CHIP to enable health officials to actively monitor and respond to both the performance of these key health providers as well as the needs of communities. With advanced analytics, artificial intelligence, and GPS built into the system to ensure data quality, accountability, and transparency, the CHIP dashboard allows health officials from the block to the district to the state level to track 500 primary healthcare indicators of the community through data collected in real time. At Khushi Baby, it is our vision to place the mother and her child at the center of the public health system, surrounded by a village of empowered and informed caregivers. And it is our mission at Khushi Baby to build a robust and accountable health system to bring this vision to the last mile.
We at Khushi Baby are digitally transforming India's public healthcare at the last mile. We at Khushi Baby are digitally transforming India's public healthcare at the last mile. Our unified mobile health interface, the Community Health Integrated Platform or CHIP, has empowered 60,000 community health workers across Rajasthan, unlocking unprecedented granularity for local health interventions and helping improve health outcomes for over 20 million beneficiaries.
Mr. Pawan Singh, Dr. Vijendra Banshiwal, Mr. Hamid Abdullah, Mr. Arul Srinivasan, and Mr. Saket Kumar to please come on the dais and answer the queries, if any. Thank you. And Sarfraz, our principal data scientist, please.
Okay, so we can just go table to table, get your brief reactions, and if you have any specific questions for any specific aspect, we can give more detailed answers. So that's the idea of this session. So why don't we start at this table, if nobody wants to volunteer? Later, okay. Who's our first volunteer? Thoughts, reactions, concerns, questions, suggestions?
Yeah, thank you, Ruchit. So my question is to the data team here. So I wanted to understand, when you were working on this entire architecture, how did you look at the overarching framework that has been developed by the National Digital Health Mission, and what considerations did you took in consideration for developing the Khushi Baby app, keeping in view that ultimately whatever it's being done eventually has to get synced with the National Digital Health Architecture?
Okay. So good afternoon. So first of all, what is my plan whenever I go to field visit is that I go with a certain objective. Like suppose if I were like, today's visit was not planned as exactly, but I would say like I was supposed to validate the MPI that has been done analysis a week back. Okay. So I would say that prior to any analysis, I would consider the field reality, the monitor's observation, and what does the standard literature says in the previous studies. So anything without the field visit, analysis means nothing. So in addition to that, the biggest barrier in public health that I see is that the ASHAs are able to motivate the women of the family, but they are not able to motivate the head of the family. I think this is the biggest barrier because those are men, and definitely there are certain sensitive questions that cannot be asked with the head of the family. And I believe ASHA is one linkage who connects with the beneficiary, with the ANMs, and it will play a major role. So today I visited a village of Salumbar block. There I've seen that the ASHA was a smart health worker. She had completed 1,300 surveys. So maybe next time when I visit the field, I'll be validating what is the MPI over in that geography, because there are many things going in and around in the village. And when it comes to the RCH planning, we see is that the biggest two indicators that we need to focus on is the early registration and the 4ANC completion. If we close the gap between these two indicators, then definitely the overall impact can be achieved within the field. So when visiting the field, I would say in summary wise, do some analysis, ask the experts, and then again after the analysis, post-validate it. And definitely the standard literature has to be considered. Thank you. I think you got the answer.
Hello. On the perspective of NHA, ABDM module, ABA module, so it connects all the healthcare application into a single platform. So where we can communicate with other modules, it easily opens an interoperability zone. So yeah, we are exactly working on that, and Khushi Baby is soon going to send all the data to ABDM server, as well as connect the beneficiaries with their health profiles.
Hi, I have a question. On what basis do you decide how the field monitors visit each of these Anganwadis and CHCs, and I mean, how is that planned out?
जी गुड आफ्टरनून. तो सबसे पहले हम क्या करते हैं, ट्रेनिंग जब हम आशा और एनएम्स को देते हैं तो उनको पहले दो ग्रुप में डिवाइड करते हैं एज के हिसाब से. अगर वो यंग एज हैं हेल्थ वर्कर और स्मार्टफोन यूज़र हैं तो उनका एक अलग ग्रुप बनाते हैं, और जो ओल्ड एज हैं और जो फीचर फ़ोन यूज़ कर रही है उनका अलग ग्रुप बनाते हैं। तो हमने अभी हमारा ये ऐसा एक्सपीरियंस रहा है फील्ड में कि जो यंग एज हैं और स्मार्टफोन यूज़र भी हैं, तो उनको 1 या 2 बार की ट्रेनिंग में वो एप्लीकेशन को अच्छे से यूज़ करना स्टार्ट कर देती हैं। तो पहला तो क्राइटेरिया ये कि हमने उनको निकाल दिया। अब मॉनिटर का फोकस रहा उन पे जो फीचर फ़ोन यूज़र हैं और जो स्मार्टफोन यूज़ नहीं कर रही थी पहले से और उनकी एज भी ज़्यादा है। पहले तो इस तरह से डिसाइड करते हैं। फिर उसके बाद हमने बहुत सारे डाटा क्वालिटी चेक्स लगा रखे हैं डाटा पे। जैसे मैं अगर बात करूँ स्पेसिफिक टू RCH डाटा की, तो हमने एक डाटा क्वालिटी चेक लगाया है कि अगर किसी MCHN पे एक ANM ने ब्लड प्रेशर भरा कुछ बेनिफिशियरी के लिए 120/80 और कुछ बेनिफिशियरी को उसने कहा कि इक्विपमेंट नहीं है मेरे पास और कुछ को कहा कि इक्विपमेंट वर्क नहीं कर रहा, तो ये उस पर हमने ब्लड प्रेशर पे डाटा क्वालिटी चेक लगाया और उसको मॉनिटर को भी भेजा वहाँ पे फिजिकली और उसको रिमाइंडर कॉल भी दी कि आपने जो MCHN किया था आपने सारी चीज़ें ठीक की हैं, लेकिन ब्लड प्रेशर में जो आपने लिया है तो एक बार उसे चेक कर लें। फिर इसी आधार पे हमने आशा को भी और ANM को भी अलग अलग ग्रुप में बांट रखा है, डिवाइड कर रखा है, फर्स्ट कैटेगरी, सेकंड कैटेगरी, थर्ड कैटेगरी। इस रिमाइंडर कॉल भी देते हैं और इसी बेसिस पे मॉनिटर को भेजते हैं वहाँ पे। इस तरह से ये प्लान करते हैं।
Hello, Ahmed. I have a follow-up question on this. Like you said, that for all those temperature measurement, like BP measurement or any other measurement, if the device is data collector is saying that she had readings for few cases or few scenarios, and she doesn't have readings for other cases. In few cases, device not working or meter reading is wrong. So what I have seen today in the field, like machine is working properly. If you will stand on that, the weighing machine is working properly, but that is giving reading something else. And machine calibration is must. We are focusing on getting the readings from the device. And like yesterday we talked about the IoT device as well. I'm not saying that we should use IoT device in the next 6 months or 1 year. However, there are existing applications. Those are available for the height as well. You can use Google Lens, that is totally free of cost, and you can measure height and then you can record it. Because today when we visited to sub center, at that time we found that the height measuring machine is not working properly. So what happened in those scenarios if you find out that machine is not working or machine is damaged, and the government officials is trying to provide the each equipment to each and every remote area. However, it's not possible until ASHA and ANM they doesn't take follow-up to get devices. So how we
हाँ, मैं आंसर करता हूँ इस सवाल का। तो मैं अपने जो अभी तक हमने फील्ड पे किया है वो बताता हूँ। तो जब हमने स्टार्ट किया था 81 ANMs के साथ किया था 5 ब्लॉक में, तो उसमें से एक ब्लॉक था सराडा। हमारी एप्लीकेशन में जैसे कल हमने दिखाया था भी डिनाइल रीजन है हर एग्जामिनेशन के, तो सराडा ब्लॉक से डिनाइल रीजन आने लगे। कहीं पे ब्लड प्रेशर नहीं था, कहीं पे वेट मशीन नहीं थी। वेट मशीन वाला डाटा हमने निकाला और सराडा के जो BCMO थे उनके साथ शेयर किया कि इस मंथ में जितने MCHN हुए हैं उनमें से इतनी जगह पे वेट मशीन नहीं है। तो उन्होंने सभी ANM की एक मीटिंग रखी और उनसे पूछा और विदिन 1 वीक वहाँ पे इक्विपमेंट प्रोवाइड कराए। ये वेट मशीन की बात कर रहा हूँ मैं। अब नेक्स्ट आपका जो अगला क्वेश्चन है उसमें ये है कि हमने कम से कम एक ये तो स्टार्ट किया कि अगर वहाँ पे इक्विपमेंट है नहीं है या है, ये आए डिनाइल रीजन से ANM फिल करे। इससे पहले क्या हो रहा था कि वो एप्लीकेशन लिख के देती थी कि मेरे सब सेंटर पे ये चीज़ें नहीं हैं, तो वो MCHN से आने लगा हमें। अब जैसा कल हमने डेमो भी किया था IoT डिवाइस से जो लिंक कर रहे हैं हमने 3-4 एग्जामिनेशन के लिए वो कर लिया है। कल मैंने सिर्फ वेट का दिखाया था। तो ये आगे बढ़ते बढ़ते इस तरह से हम लिंक करेंगे और डाटा जिस तरह से वो IoT पे जैसे ही वो वेट मशीन पर खड़ी होती है तो ऑटोमेटिक आने लगेगा। अभी क्योंकि वो लिंक नहीं है और हमने अभी इम्प्लीमेंटेशन स्टार्ट नहीं किया, उसको रोकने के लिए हमने जैसा भी मैंने बताया ADQC बना रखे हैं, डाटा क्वालिटी चेक। तो जैसे मैं ब्लड प्रेशर का एग्जांपल फिर से देता हूँ ये कि एक सेशन पे 10 महिलाएं आईं और 10 के 10 बेनिफिशियरी का उसने 120/80 भरा, तो वहाँ वो डाटा को फ्लैग करता है कि पॉसिबल नहीं है ये कि सारे बेनिफिशियरी का 120/80 ब्लड प्रेशर हो। तो इस तरह से अभी के लिए हम कुछ ऐड करना चाहेंगे।
सो कैलिब्रेशन एक ऐसी चीज़ है, आप वेइंग स्केल का कैलिब्रेशन मान सकते हो कि आपकी एएनएम कर देगी, लेकिन बीपी इंस्ट्रूमेंट और ये ऐसे डिवाइसेस है जिसका कैलिब्रेशन लेवल उनके बस की बात नहीं है. सो आई वुड से कि उस कंडीशन में रिप्लेस करना ही बेस्ट ऑप्शन है, क्योंकि कैलिब्रेटेड प्रोडक्ट आप भी जानते हैं कैसे हैं मार्केट में.
Now on height, why I'm saying is because when I visited today, we just try to use the NFC chip and try to get the data, existing data for the follow-up visit. And at that point of time, I just seen a case where data collector is saying that female height is 171 centimeter, 171 centimeter, and with I can when I see in her, I just see her height was nearby 150 to 160, nearby that. So what kind of things you can do in these kind of scenario, because you are not observing each and everyone, and this is the one of the major implication. And using the machine learning, when we try to use machine learning, I appreciate, and I am pretty much sure that you are the only one who is using machine learning in public health domain right now in India to get the data quality checks, because monitoring and evaluation is something that is very important. And in these kind of scenario, we cannot say that 171 is outlier in the female. No, that is not an outlier. How can we solve these kind of scenarios? Your field monitors is there in the field. So in these kind of cases, and even if he is not able to recognize those cases, then it is a issue, a quality issue, which can be noticed and which can be used as a lesson, and how to resolve these things, that can be, we need to think about it.
Okay, so this cannot be solved in a span of 1 or 2 years. This is a data quality problem and it's a precision public health problem. But this can be solved by ASHA. So as most of the ASHAs have completed their surveys, the next thing is that they're good at quantity, is to improve the quality over time. And once they do that, definitely in machine learning it's garbage in, garbage out. Okay, so we'll validate those results every now and then. The machine learning will be keep on iterating. But yes, it's a behavior that has to be looked after, and we are continuously working on that. Maybe I cannot say not even 2 years, 3 years, 4 years, or 5 years. There's no specific time for it. It depends upon the trust between us and the health workers.
Thank you.
Hi, first of all, I'd like to very highly appreciate how this has been arranged. It takes a lot of courage to put a team in front like this and answer questions and open up as an organization to just for everyone to see every aspect. It takes a lot of courage. So congratulations for pulling this off. A huge, huge applause to the whole team. And thank you for having us to see what you guys do and being extremely open to feedback on every level. So one is that, and I was just curious about two things. One is that her team member, so again, congratulations on building a very robust team. Each team member is so dedicated and very clearly knows what they're doing, which I've not come across for the whole team a lot of times. So my question is on two fronts. One is that operationally, internally, how do you ensure that the flow of information between different teams is designed such that, because from field to product and product to field, since you're building it, not all of it is automated, right? So how is operationally the design of flow of information designed? That's one question. And second question is more from a way forward for the organization. So one is, of course, deepening the impact with your product in a certain region. Or would you like to take this to different regions and then collaborate with other organizations working on behavioral aspects with the community? So what would be your different paths as you go forward?
Yeah, thank you. So actually my name is Pawan Singh as a product lead. So actually your question is related with me. मैं कहना चाहूँगा कि आपका थोड़ा सा बड़ा सवाल है, क्योंकि ऑपरेशंस लास्ट माइल से लेके और प्रोजेक्ट का डिज़ाइन और फ्लो सब इंक्लूड है. डेफिनेटली मैं बस कहना चाहूँगा कि एक्चुअली जो प्रोसेस है हम लोगों का वो बहुत क्लियर कट है। अब प्रोसेस हम लोग ऑफिस में डिसाइड नहीं करते हैं एक्चुअली, और मल्टीपल पीपल इन्वॉल्व सिंगल प्रोसेस। आपको ये डिजिटलाइजेशंस की तरफ जाना है, ये पेपर वर्क है, इसको डिजिटलाइज करना है। आपके क्या व्यू हैं, आपके क्या व्यू हैं, ग्राउंड लेवल पे जो एक्सपीरियंस लोग हैं उनके साथ बैठ के बात करनी है। एक नहीं 10 आशा से बैठ के बात करनी है कि उनके एग्जिस्टिंग चैलेंजेस क्या हैं, हमें वहाँ से अपना फीडबैक लेके आना है। सेकेंड थिंग, सेम हाई लेवल पे जो बैठे हैं CMHO, RCHO एंड अदर थिंग्स, उनके क्या एक्सपेक्टेशंस हैं। थर्ड थिंग्स, गाइडलाइन क्या कह रही है, वैलिडेशंस क्या कह रहे हैं। फोर्थ थिंग्स, यूजर हमारा किस लेवल पे है तो UI कैसा होगा। ठीक है, ये तो हो गया। मल्टीपल फ्रैगमेंट, मल्टीपल फ्लो, मल्टीपल प्रोग्राम्स, ब्रांचेस ओपन्स हो रही हैं, कैसे आप कनेक्ट करोगे, कौन सी ब्रांच कैसे निकालोगे, यूजर कैसे समझेगा कि हम कहाँ पे जा रहे हैं, ये यहाँ से निकल के कहाँ जाएगा। तो हम लोग ग्राउंड से काम करते हैं, फीडबैक लिखते हैं, प्रोटोटाइप पेपर पे, जैसे कि आपने देखा होगा बाहर हम लोग प्रिंट आउट लेते हैं, हम जाते हैं, बात करते हैं, देन इंटरनली डिस्कशंस होते हैं, फिर फीडबैक होते हैं। यहाँ पे बहुत डेवलपमेंट पार्टनर भी हैं, उनके आइडियाज़ भी आते रहते हैं, उनके भी डिस्कशंस होते हैं, तो हम उसको भी इनकॉर्पोरेट करने की कोशिश करते हैं। मे बी आज जो फील्ड हम लोग गए हैं, जो हमारे साथ टीम थी, ये लॉट ऑफ क्वेश्चंस माइंड में थे, ये कैसे हो सकता है, या क्या ये हो सकता है, ये नहीं हो सकता है। तो ये मेरा भी लर्निंग है। मैंने 2-3 पॉइंट बहुत वैलिड इन्होंने सजेशन दिए, तो मेरे माइंड में है, जब मैं डिज़ाइन करूँगा डेफिनेटली उसको इंक्लूड करूँगा। ये भी प्रोसेस का पार्ट है। सो डिज़ाइन करना, प्रोसेस, रिसर्च पेपर, गाइडलाइन, रूल्स, लॉजिक्स, UI according the user, then feedback from the user, then finalize, then communicate the development team, then operation team also pass the feedback here for the design and flow. After that हमारे Android developers and front end developers like
सो बेसिकली हम तीनों साथ ही बैठे हैं। अगर मैं बात करूं तो डिज़ाइन साइड से पवन जी ने सारा बता दिया कि कैसे कैसे हम डिज़ाइन कर रहे हैं, यूज़र का फीडबैक होता है, क्योंकि UI जो है वो सबसे इम्पॉर्टेंट है। आशा, ANM और MOIC जिसके लिए भी हम मॉड्यूल बनाए, अगर उनके काम ना आए तो उसका कोई फ़ायदा नहीं है। तो सबसे पहला डिज़ाइन और सारी चीज़ें हमें पवन जी से मिलती है, देन उसको मेरी टीम जो मेरे साथ में है सब मिलके एंड्रॉयड डेवलपमेंट होता है और बैकएंड डेवलपमेंट होता है बेसिकली। तो एंड्रॉयड डेवलपर्स की हमारी पूरी एक टीम है, और साथ में हमारे पास बैकएंड लीड भी है, यहाँ पे बैकएंड लीड भी हमारे साथ बैठे हैं। तो वो प्रोसेस फिर मेरे पास आता है। मेरे पास प्रोसेस आने के बाद मैं उसका डेवलपमेंट कराता हूँ। पूरा डेवलपमेंट कराने के बाद मेरी पूरी डेडिकेटेड टेस्टर्स की टीम है जो पहले उसको टेस्ट करती है। उस समय जब टेस्टिंग होती है उसके बाद हम एक फील्ड टेस्टिंग ऑर्गेनाइज कराते हैं, जो कि मेरे साथ में बैठे हामिद, उनकी टीम करके देती है। ये हमारा पूरा प्रोसीजर है, और इसके बाद में हम हैंड ओवर करते हैं टू इम्प्लीमेंटेशन। सो मेरे बगल में हामिद बैठे हैं, ये इम्प्लीमेंटेशन को देखते हैं। सो बेसिकली ये पूरा लूप हम कवर कर रहे हैं इन्हीं 3 चीज़ों के साथ, कि पहले डिज़ाइन पे फोकस करेंगे इन डिस्कशन विद डेवलपमेंट पार्टनर्स, गवर्नमेंट ऑर्गेनाइजेशंस, और गाइडलाइंस को फॉलो करते हुए, और इसी तरीके से हमारा सारा प्रोसीजर है।
हाँ, मैं इसमें कुछ और ऐड करना चाहूँगा। जैसा आप कम्युनिकेशन पर बात कर रही थी, कम्युनिकेशन की एक टीम है हमारी, पिछले लगभग 4 साल से वो हमारे साथ काम कर रहे हैं, और 4 साल में वो लगातार डेली आशा वर्कर से बात करते हैं, इनएम से बात करते हैं, उनकी प्रॉब्लम सुनते हैं। तो एक मैं ये ऐड करना चाहूँगा इसमें कि आज तक 4 साल से आज तक भी किसी एक भी दिन उन्होंने सुबह में आके ये नहीं कहा होगा कि आज कॉल करने का मेरा मन नहीं कर रहा। डेली वो, उनको पता है, मोटिवेटेड हैं। जबकि आप बात कर रहे हैं 1000 लोगों से, तो हो सकता है कि गुस्सा आ जाए, वो बंद कर दें अपना काम, लेकिन आज तक कभी ऐसा नहीं हुआ। फील्ड पे जो हमारी टीम है, हम डेली कॉल रखते हैं, डिसाइड करते हैं, प्लान बनाते हैं, व्हाट्सअप ग्रुप बना रखे हैं, स्लैक पे हम कम्युनिकेशन करते हैं। आज तक कभी ऐसा नहीं हुआ कि विद इन सेकेंड जवाब नहीं आ गया हो, कभी भी ऐसा नहीं हुआ। फील्ड टीम को जो भी काम दिया जाता है, वो जिस लोकेशन पे है वहाँ से 35 किलोमीटर जाना है, वो सिंगल एक ही बार में उसको यस करता है। कभी भी तो मतलब टीम में सिर्फ एक बंदा आया, दो बंदा आया, मोटिवेटेड नहीं है। ग्राउंड लेवल पे जो भी काम कर रहे हैं वो भी मोटिवेटेड है। ये तो हमारा इंटरनल हुआ डिस्कशन के, जब हम कम्युनिकेशन एक दूसरे के साथ शेयर कर रहे हैं। अब मैं आपको बताता हूँ हेल्थ वर्कर के साथ कैसे कम्युनिकेट करते हैं हम। तो स्टार्टिंग जब हमने की तो उनको वॉइस मैसेजेस देते थे, जैसा मैंने कल डेमो भी किया था। तो ये वॉइस मैसेजेस सिर्फ बेनिफिशियरी के लिए नहीं है, हेल्थ वर्कर के लिए भी है। फिर हम उसको देखते हैं कि उसका इम्पैक्ट क्या आ रहा है। हमने एक नया बिल्ड अपलोड किया और एक हफ्ते तक वॉइस मैसेजेस दिए, तो देखा कि कितने हेल्थ वर्कर ने वो बिल्ड अपडेट कर लिया। अगर वो इम्पैक्टफुल नहीं है तो हम उनको टेक्स्ट मैसेज करते हैं, उनको लिंक भेजते हैं। हमने इनबिल्ट वीडियो लिंक डाल रखे हैं एप्लीकेशन में, यूट्यूब पे डाल रखे हैं। और लगभग पूरे राजस्थान में हर सेक्टर के, हर ब्लॉक के, हर डिस्ट्रिक्ट के लेवल के हमारे पास नंबर ऐड है हमारे व्हाट्सएप ग्रुप में। तो इस तरह से हेल्थ लेवल पे, हेल्थ वर्कर लेवल पे कम्युनिकेट करते हैं। तो ये आई थिंक आंसर है आपके क्वेश्चन का।
Thank you for explaining so much in detail. Thank you.
कोई और किसी का क्वेश्चन, या आप सजेशन भी दे सकते हैं, एक्सपीरियंस शेयर कर सकते हैं अपने फील्ड का। अभी आज आप एएनएम आशा से मिल के आए हैं, एमसीएचएन पे कल जो हम बात कर रहे थे उसके बारे में आप अपना एक्सपीरियंस शेयर कर सकते हैं।
Hello, I'm Preeti from Seva Mandir. I really want to congratulate Khushi baby for such a great achievement. और ख़ासकर आपकी टीम को, जो आप ऊपर बैठे हैं, और मैं बिल्कुल आपसे एग्री करती हूँ कि बहुत अच्छा मौका है कि डायरेक्ट उन लोगों से बात करने का मौका मिल रहा है जिन्होंने इस पे खुद से काम किया है। और ये मौके कम होते हैं, पर बहुत खुशी बेबी को धन्यवाद कि आपने बहुत ही अच्छा कॉम्प्रहेंसिव, आपने बहुत ही सुंदर कॉम्प्रहेंसिव ऐप बनाया है। अभी भी ग्राउंड पे देखिए बहुत सारी दिक्कतें हैं, लेकिन एक लेवल पे लगता है कि आज जो बन गया है और जितनी चीज़ें आप उसमें ला पाए हैं, उसको भी अगर इम्प्लीमेंट कर देते हैं तो बहुत एक सुंदर दृश्य आगे की ओर दिखता है। मुझे पता है उसको और सुंदर बनाया जा सकता है आगे के लिए। एक दो चीज़ें जो मैं जोड़ना चाहती हूँ, आपने एक बहुत ही अच्छी बात यह है कि जो ऐप बनाया गया है उसमें आप लोगों के अनुभव डायरेक्ट कम्युनिटी के साथ काम करने के शामिल थे, और वो एक बहुत बड़ा अचीवमेंट है। मतलब कई बार हम लोग भी अगर बात करते हैं हमारे यहाँ, तो हम लोग आउटसोर्स करने की बात करते हैं टेक्नोलॉजी में, तो वो एक फ़र्क हो जाता है कि कम्युनिटी का एक्सपीरियंस आप रखते हैं और बना कोई और रहे हैं। पर आपका जो खुशी बेबी का एक कॉम्बिनेशन है कि आप डायरेक्ट इम्प्लीमेंटेशन में भी हैं और नए नहीं आए हैं, आप काफ़ी सालों से कर रहे हैं। आप सरकार को भी अच्छे से जानते थे, आपको दिक्कतें पता थी, और आपको पूरा सरकार का जो मॉडल है वो भी पता था, और इसीलिए आप इतना बेखूबी से इसको खूबसूरती से MOIC, आशा और ANM तीनों ऐप पे सोच पाए और कर पाए। सो आई रियली वांट टू कंग्रेचुलेट एंड रुचित, स्पेशल टू योर ब्यूटीफुल टीम, जिन्होंने इतना अच्छा, दे हैव ऑफर्ड अ ग्रेट हॉस्पिटैलिटी टू अस सिंस लास्ट 10 days, you know. अच्छा, मेरे एक दो बस प्रश्न नहीं हैं, अगर आपके पास जवाब हो तो दीजिएगा प्लीज़। मैं पूछना चाहती थी कि जो ऐप आप बना चुके हैं और सरकार अब इसको चाहती है कि राजस्थान में इम्प्लीमेंट करे, क्या कोई डिसेमिनेशन और शेयरिंग का तरीका होगा आगे? मतलब क्या आपने सोचा है कि कैसे ये ऐप अगर एक बार यूज़ में आ जाता है तो कैसे इसको आप आगे शेयरिंग में और लोगों के साथ शेयर करने में लाएंगे? और उससे जुड़ता हुआ एक और बात है कि हाउ आर अदर स्टेक होल्डर्स और NGOs गोइंग टू बेनिफिट फ्रॉम दिस ऐप? हमारी जैसी संस्थाएं जो आंगनवाड़ीज़ के साथ, आशास के साथ क्लोज काम करती हैं, हम लोग कैसे इससे जुड़ पाएंगे और कैसे इस ऐप का लाभ ले पाएंगे, अगर आप वो भी बता सकें। और एक और चीज़ है कि ये जो ऐप हमने तैयार किया है, आपको क्या लगता है कि आशा और ANMs का कितना ऑफन इनका ट्रेनिंग्स हुआ करेगा ये समझने के लिए और सीखने के लिए? क्योंकि ये बहुत कॉम्प्रहेंसिव लगता है। आज हम जिस फील्ड में गए थे वो बहुत अच्छे से कर पा रहे थे, तो थोड़ा, अगर आपने कल कहा कि बजट इसके लिए अप्रूव हो गया है और आशास को मोबाइल फ़ोन्स दिए जाएंगे, तो आपको क्या लगता है कि उस पे आपको कितना इन्वेस्ट करना पड़ेगा? थैंक यू सो मच वंस अगैन।
पहले मैं आखिरी वाले प्रश्न का जवाब देना चाहूँगा कि एक्चुअली हम लोगों का अप्रोच है, यहाँ पे हामिद जी बैठे हैं, एक्चुअली इम्प्लीमेंटेशंस ऑपरेशंस देखते हैं और ट्रेनिंग भी, और मास्टर ट्रेनर्स भी हैं हमारे। एक्चुअली हम लोगों ने होल एप्लीकेशन पे कभी ट्रेनिंग देने की कोशिश नहीं की। जितने भी मॉड्यूल बने हैं हम लोग इंटरवल में एंट्री किया, जैसे DHS, आपको DHS करना है, उसके बाद ऑटोमेटिकली फैमिली प्लानिंग का हमारा ब्रांच ओपन हो जाता है। बट उनको जब भी आप ट्रेंड करेंगे, जहाँ पे भी ट्रेंड करेंगे, वो अपना फैमिली प्लानिंग मॉड्यूल स्टार्ट हो जाएगा। लेकिन फैमिली प्लानिंग से ही आपका RCH जुड़ा हुआ है, तो वो हम दोनों मॉड्यूल एक साथ में ट्रेनिंग देते हैं। उसके बाद चाइल्ड हेल्थ, PNCs, ये तो हम लोगों ने मॉड्यूल बाय मॉड्यूल हमेशा से लोगों को ट्रेंड किया, और मॉड्यूल बाय मॉड्यूल ट्रेनिंग से हमें फीडबैक भी मिले, क्योंकि ट्रेनिंग में जब फीडबैक होते थे कॉम्प्रहेंसिव पिक्चर निकल के आती है आशा के साथ, क्योंकि जब वो लॉन्ग टर्म ट्रेनिंग्स होती है 2 डेज़ 3 डेज़ की, हमने उसको भी इनकॉर्पोरेट किया। तो मैं तो यही कहना चाहूँगा कि एक साथ ट्रेनिंग से अच्छा है कि आप छोटा छोटा ट्रेनिंग दें, अगर आपको धीरे धीरे कोई भी प्रोग्राम इम्प्लीमेंट करने हैं। दूसरी चीज़, हमने छोटे छोटे मॉड्यूल के यूट्यूब वीडियो बनाए हैं, हर एक पर्टिकुलर मॉड्यूल्स के, हिंदी में, इंग्लिश में, और वो एप्लीकेशन में इनकॉर्पोरेट है। जो लोग ट्रेनिंग देने के बाद भी उनको बार बार वीडियो देखते हैं तो वो सेल्फ ट्रेंड भी करते हैं। और हमारी फील्ड टीम उतनी लिमिटेड है कि वो सिर्फ उनको हैंड आउट सपोर्ट देते हैं, जैसा हमने डिवाइड किया कि हमारा ग्रुप कैसे NM का हमने बनाया है। हमारा मकसद ये नहीं है कि मैन पावर का यूज करना है ट्रेनिंग का। हाँ, आगे मास्टर ट्रेनर, जिस तरीके से गवर्नमेंट की पॉलिसीज़ हैं, मास्टर ट्रेनर CSC PSC लेवल पे वो कर सकते हैं ऐसे। उससे पहले वाला क्वेश्चंस कि आंगनवाड़ी के साथ हम लोग काम कर रहे हैं, वर्कर के साथ अदर डेवलपमेंट पार्टनर्स हैं, डेफिनेटली। रुचित हो सकता है कि मोर और एक्सप्लेन करे, वी हैव द फ्यूचर प्लान, क्योंकि ऑलरेडी हम सोच रहे हैं, अभी से नहीं, लास्ट 1 ईयर से सोच रहे हैं आंगनवाड़ी वर्कर का इंटरफेस, CHO का इंटरफेस, आशा सुपरवाइज़र का इंटरफेस, क्योंकि कुछ सुपरवाइजरी में है, कुछ सर्विस प्रोवाइडर में है, तो उनके जो रोल और रिस्पॉन्सिबिलिटीज़ हैं उसको सिंगल एप्लीकेशन में कैसे इंक्लूड किया जाए। एग्जांपल मैं देना चाहूँ कि अंडर 6 ईयर के सारे बच्चे आंगनवाड़ी वर्कर को दिख जाएं, वो मंथली अटेंडेंस, डेली बेसिस पे आंगनवाड़ी पे बच्चों की अटेंडेंस दे पाए, मंथली मेजरमेंट का डेटा चढ़ा पाए, आफ्टर डेटा सेम मैम को ऑटोमेटिक आइडेंटिफाई करके उनका ट्रीटमेंट का फॉलोअप कर पाए। दैट इज एक सिंपल सिनारियोस। तो वी हैव एक्चुअली हम लोग उस पर बात कर रहे हैं, सोच रहे हैं, डेफिनेटली मे बी कि जल्दी से जल्दी वो चीज़ आप देखें। रही अदर पार्टनर, ये डेटा की बात रुचित ने बहुत बोला कि डेटा को यूज कैसे किया जाए। अलग अलग सेक्टर के डेवलपमेंट पार्टनर अलग अलग सब्जेक्ट पे काम करने वाले हैं, डेफिनेटली वो लोग डेटा को यूज कर सकते हैं हमारे साथ काम करके, गवर्नमेंट के साथ काम करके, कि डेटा अगर है तो इसमें कोई डिनाई नहीं कि उस डेटा पे एक्शंस लेने वाले कौन है। एक्शन लेने के लिए वो डेटा ओपन होना चाहिए। डेफिनेटली मैं भी इत्तेफाक रखता हूँ कि जब डेटा एक जगह है, अच्छा डेटा है, क्लीन डेटा है, वो लोग भी अपना एक्शन ले सकते हैं, और हो सकता है कि उनका उस डेटा के साथ नेक्स्ट अलाइनमेंट हो, नेक्स्ट उनके इंटरवेंशंस हो, तो आल्सो वी कैन कनेक्ट। एग्जाम्पल, फैमिली प्लानिंग्स, कितने लोग हैं जो नॉन मेथड्स हैं, कितने लोग हैं जो उनका ट्रेंड क्या चल रहा है, लेकिन उस चीज़ पे इंटरवेंशन करने के लिए कोई पार्टनर है, वो डेटा हम ये दे सकते हैं, वो इंटरवेंशन का उसी डेटा के साथ इनकॉर्पोरेट करके अपनी रियल पिक्चर देख सकते हैं। These are scenarios. So we have multiple thought, बहुत सारे सिनारियोस हैं, तो हम उनके साथ भी जा सकते हैं। थैंक यू।
मैं कुछ और इसमें पॉइंट ऐड करना चाहूँगा। जैसे एक न्यूट्रिशन का प्रोजेक्ट है शायद सेवा मंदिर का, खुशी, तो उसमें आप किस तरह डिसाइड करती हैं कि कहाँ न्यूट्रिशन प्रोवाइड होना चाहिए, उसमें कुछ आप डिस्ट्रीब्यूशन करते हैं बच्चों के लिए, तो हमारा आपके साथ कैसे कोलैबोरेशन हो सकता है। हमारे एप्लीकेशन का कल हमने डेमो किया, हमारे पास डाटा आता है फील्ड से डायरेक्ट, आशा आइडेंटिफाई करके भेज रही है एएनएम कि ये वो सारे बच्चे हैं जो मॉडरेटली एनेमिक हैं या सिविली अंडरवेट हैं, तो उस डाटा को हम आपके साथ शेयर कर सकते हैं, एक ये वे बन सकता है। दूसरा, जैसे आरबीएसके की टीम काम करती है, ये मैं बता रहा हूँ कि डाटा को जो हमारे पास ग्राउंड से आया है किस तरह यूज़ कर सकते हैं। अभी आरबीएसके की टीम किस तरह प्लान करती है कि वो आंगनवाड़ी वाइज डिवाइड करती है कि इस आंगनवाड़ी पे 50 बच्चे हैं तो 50 के 50 बच्चों का एग्जामिनेशन करना है। लेकिन हो सकता है कि दूसरी आंगनवाड़ी पे कोई ऐसा बच्चा हो जिसको कल ही ट्रीटमेंट कराना है, वो सीवियरली अंडरवेट है, उसको अभी रेफर करना है। तो ये डाटा इस तरह भी यूज़ किया जा सकता है कि हम आरबीएसके का प्लान बना लें, उनको बताएं कि प्रायोरिटी किस तरह बनानी है। ये दूसरा पॉइंट हुआ। तीसरा पॉइंट ये, जैसे फैमिली प्लानिंग का पवन जी बता रहे थे, फैमिली प्लानिंग पे भी बहुत सारे लोग काम कर रहे हैं। डाटा डेट क्रॉस हो जाती है, ड्यू लिस्ट पड़ा रहता है उसमें, ड्यू में हम ये डाटा शेयर कर सकते हैं, बेनिफिशियरी को ऑटोमेटेड वॉइस कॉल दे सकते हैं, रिमाइंडर दे सकते हैं। इस तरह से हम दूसरे लोग जो डेवलपमेंट पार्टनर्स हैं वो इस तरह से इस डाटा को यूज़ कर सकते हैं।
डाटा शेयरिंग विद गवर्नमेंट बेसिकली, आप हम लोग जब कोलैबोरेशन करेंगे तो उस समय हम गवर्नमेंट को लूप में लेते हुए डेफिनेटली डाटा वगैरह ये सारी चीज़ें शेयर कर सकते हैं, क्योंकि अल्टीमेटली जो डाटा है वो स्टेट डाटा सेंटर का है, हम ओनर नहीं है, वी आर कस्टोडियंस ऑफ डाटा। जी, यही पॉइंट ऐड करना था।
और एक आप पूछ रही थी कि आगे का क्या प्लान है, किस तरह इसको रोल आउट करने का प्लान है। तो अभी हमारी जो प्रोजेक्ट चल रहा है, जो हम डाटा आपके साथ कल शेयर कर रहे थे, उदयपुर का भी कर रहे थे, तो हमारा ये मेथड है कि गवर्नमेंट इस प्लेटफॉर्म को एडेप्ट कर ले, गवर्नमेंट के एम्प्लॉय हैं। अब यहाँ पे उदयपुर में तो हमारे पास मॉनिटर्स हैं, लेकिन उदयपुर के अलग भी डाटा आ रहा है, वहाँ पे भी ट्रेनिंग होती है। वहाँ से किस तरह हो रहा है, वहाँ तो मॉनिटर जाने के लिए नहीं है। हमारा जो कल रोहित सर ने भी मेंशन किया था मिशन लाइफ सेविंग, उसमें लगभग हमने 1.5 करोड़ बेनिफिशियरी का डाटा ट्रैक किया था, और वो ऑल ओवर राजस्थान से था। तो हमारा ट्रेनिंग का भी ये रहता है मेथड कि हम पहले वर्चुअल एक ट्रेनिंग रखते हैं डिस्ट्रिक्ट लेवल पे, डिस्ट्रिक्ट लेवल वाले जाके ब्लॉक लेवल पे ट्रेन कर देते हैं, और ब्लॉक वाले सेक्टर लेवल पे कर देते हैं, और सेक्टर लेवल पे एक बंदे को आइडेंटिफाई कर लेते हैं जो विलेज लेवल आशा एएनएम को ट्रेनिंग देता है। तो यही एक मॉडल है कि गवर्नमेंट उसे अडेप्ट कर ले, हम उसके लिए कोई कॉस्ट वगैरह भी अभी नहीं ले रहे हैं उनसे, और इस तरह से हम दूसरी जगह भी रोल आउट कर सकते हैं।
एडिंग टू दैट पॉइंट, एक चीज़ है, एक प्रोवर्ब है, लोग कहते हैं वेयर ह्यूमन कैन नॉट रीच टेक्नोलॉजी कैन रीच देयर। सो बेसिकली जब डेटा शेयरिंग का बात होता है, रिसर्चर्स विल प्ले एन वेरी इंपॉर्टेंट रोल। तो हम लोग बेसिकली डेटा प्रोटेक्शन लॉ भी अभी पास होने वाला है विद इन नेक्स्ट फ्यू मंथ्स और अ ईयर। तो डेटा हम लोग एनोनिमाइज फॉर्मेट में शेयर करते हैं, जस्ट इन नंबर्स, सो दैट हमें जो भी रिजल्ट मिला है वो उनके साथ शेयर करेंगे, विच विल बी एविडेंस बेस्ड रिजल्ट्स, and this way the researchers can collaborate. And when it comes to the app sharing, app development जो होता है, उनको जो indicators चाहिए उस तरीके से हम लोग पार्टनरशिप कर सकते हैं, उसी बेस में फॉर्मेट एप्लीकेशन डेवलपमेंट हो सकता है। थैंक यू।
Hello, good afternoon. First of all, congratulations to Khushi baby for hosting a wonderful event. So I have a very small question in general. So there are already a lot of apps out there, which I think sir very correctly mentioned yesterday, कि apps बहुत सारी आती हैं and yet उनकी implementation and utilization is not that effective, and whenever new IT partners come in, whosoever, they create a new interface, they create a new app, and then the work has to be redone again, irrespective whether there's a hard copy or not, everything has to be done. So my first question is ki, was there any plan of how you integrating the currently existing apps in the government system in this particular app or anyone's? Instead of like refilling data you could integrate already the data existing in the government portals into one single place, which you were discussing about, which you were mentioning yesterday कि सारा integration हम एक ही जगह पे एक platform पे कर पाएं. That is my first question. Second, as we know, most of the indicators that we are capturing, especially by ASHA and ANMs that people have gone ground, would see कि they have a lot of registers that need to be maintained. Could there have been a possibility where you could have added an option of scanning those data just so that it enters automatically itself, because the technology is available now? So these are my two questions connected for Khushi baby. How are you taking this? Because I truly believe in the what sir statement said, that where people can't reach, technology can, and I think digitization and IT is the future of the healthcare sector and development sector very strongly. So how would you answer to that, please? Thank you.
Hi, thank you very much for bringing that question. So basically पहली चीज़ जो आपने स्टार्ट करी कि बहुत सारे जितने भी डेवलपमेंट पार्टनर्स होते हैं सब अपना अपना एक एप्लीकेशन बनाते हैं, सब अपना अपना एक मॉड्यूल बनाते हैं. तो हम सबसे पहले बात ये करेंगे कि हमने शुरू से जो कल से अगर आपने डेमो वगैरह सारी चीज़ों को देखा होगा तो हम प्लेटफॉर्म की बात कर रहे हैं. हमारे पास ऐप्स भले ही डिफरेंट डिफरेंट हो लेकिन हमारा प्लेटफॉर्म एक ही है जो एक सेंट्रल सर्वर पे बेसिकली सारे डेटा को लेके जाता है. आशा के लेवल का डाटा आशा को मिलता है, एमओ के लेवल का डाटा एमओ को मिलता है. लेकिन साथ में आपने ये भी देखा होगा कि हमने प्रसव वॉच एप्लीकेशन जपाइगो का जो है उसको हमने साथ में इंटीग्रेट किया है. इसी तरीके से जितने भी प्लेटफॉर्म्स हैं हमारा फ्यूचर पर्सपेक्टिव है हम उनके साथ में इंटीग्रेशन कर सकें. लाइक से निश्चय डेफिनेटली हम चाहेंगे कि उससे हम हमारे टीबी के डाटा को लिंक कर सकें और ऑफलाइन सेटिंग पे सारी चीज़ें एक दूसरे के साथ में लिंक हो. क्योंकि हमारा भी एक तरह अगर आप बात करेंगे क्योंकि हम सारा डाटा हमारा गवर्नमेंट का है, हमारा खुद का साइंड एमओयू है, तो इट कैन बी सेड कि ये गवर्नमेंट प्लेटफॉर्म है, राइट. बात करी जाए कि भाई स्कैन होके और इस तरीके से डाटा को भेजा जा सके, लेकिन आप भी जानते हैं और मैं भी जानता हूँ कि रिटर्न जो चीज़ है और एक टाइपिंग वाली चीज़ है. अगर वो टाइप हुआ हुआ डाटा है डेफिनेटली दैट कैन बी लाइक यूज्ड इन अ ओसीआर रीडर फॉर्म, और उस टाइप जो भी रिटर्न चीज़ है उसको ओसीआर से हम रीड कर सकते हैं. लेकिन हाथ से लिखे हुए में ए सी भी बन सकता है और बहुत सारे चेंजेस भी आ सकते हैं. तो आई डोंट थिंक कि वो फीजेबल है. लेकिन हाँ डेफिनेटली फ्यूचर में अगर ऐसी कोई टेक्नोलॉजीज इन्वेंट हो जाती है या अगर फ्यूचर में हम भी कर पाए तो हम उस चीज़ को करना चाहेंगे. जो एग्जिस्टिंग रिकॉर्ड्स है उनको कैसे भी हम लाइक डिजिटाइज कर पाएँ. ऐड करना चाह रहे हैं आप? ओके, या दैट्स आई गेस यू गॉट योर आंसर.
Hello? Hello. Okay. Yeah, so I just want to add a few points to some of the questions that were mentioned. You know, as it relates to the different apps, this is an important point. You know, we want this to be an open marketplace where whether you're a Department of Health at the state level, ministry level, district level, you can choose what you want to use. And Ayushman Bharat is trying to follow that concept, where that all of these different digital technologies are sharing data using a common language. This is one example of an interface where we are able to simplify and streamline the work across multiple programs. This is one of multiple examples that are working in different parts of India. So we are not against any other application or platform. Ultimately, we are trying to collect the same data so that way ultimately we can make impact on the ground. We are doing it in our own way, with our own thought, in our own field experience. We're trying to put the best that we can based off our local experience. And certainly if other states want to take it up, pilot it, trial it, connect it with other systems, we are more than happy to experiment with that. In fact, we recently started a pilot in Andhra Pradesh where the National Health Mission guidelines are the same basic 500 indicators you need to take. The RCH register is the same. The language is different. There are some different state-specific indicators. So there's some customization that needs to be made. Some states will want to add a particular innovation. Like yesterday we talked about the digital MCP card for beneficiaries. We talked about having a WhatsApp connection for beneficiaries to follow up and give them learning content or awareness content. So these types of things, we want to have a platform in which other things can plug in. And in order for us to have a platform in which other things can plug in, the architecture needs to be made in such a way that things can plug in. So now things are moving towards like a microservices type architecture where you're building things in modules. And at the same time, the way that data is exchanged also needs to be using a common language. And that's what Ayushman Bharat is trying to do through its health data exchange standards that they're creating. So that is kind of our future direction. It does need to be like everyone needs to come under one umbrella. And then, you know, the applications, some departments will choose certain applications and have certain partners work together to build off maybe one application will be the base, and then there will be some things that will be built around it. So right now we are currently in the process, like we mentioned, Nikshay portal, NCD portal, RCH 2.0 portal. These are all big portals that have big data sets that need to start getting the data that we're collecting. We're actively working on getting that set up, of course with the government support. PCTS, which is Rajasthan's own portal, Asha Soft, which is used to pay Ashas based off the data. These are also high priority portals that we're trying to link with. And of course, making sure all the data is compatible with Ayushman. I want to touch also on Pawan's point, which is very important, goes back to what Preeti was asking, is that we want the data to be accessible for development partners. That's one thing. Of course, with the government's permission and all the data sharing protections. But now if we know on a village level basis for 35,000 villages across Rajasthan, which villages have the highest unmet contraceptive need, which villages have the lowest ANC coverage, which villages have the highest burden of zero-dose children, or the highest burden of low birth weight children. And there are related NGOs, development partners that are based in that village or based in those surrounding village, definitely they should get the data. And there should be a process for them to be able to apply, to be a part of, as an authorized user who can access this data in some kind of specific format that is also able to protect the data privacy of the beneficiaries. And in the same way, it's not just about sharing data. As Pawanji was also mentioning, this application is need not be limited to the role of ASHA, A&M, and medical officer. Now you have different types of health workers that are coming in, the CHO. You have different teams that are getting deployed, outbreak investigation, RBSK team. There are different types of roles that are being created, the LHV, the supervisors. So they also should have a way to gain access to this data. And even in due course, when we were working on COVID-19, the need was such that they had basically made a ad hoc cater of para-health workers. So they had enrolled even school teachers and poll booth workers to help go and help us conduct the door-to-door survey, because that was the need of the hour then. So we actually had made a way for those types of special groups or even citizen groups to log into the app. So even that can be done in a future, in a future time course, depending on the need. And then, another thing that we ultimately want to do is we want to connect this back to the beneficiary. So giving them the feedback is also very important. So they should have their own, whatever, Ayushman Bharat app. They should be able to see it, or they should have some way to get that data back. That's also very important. So, I mean, that's in terms of our future vision and kind of how we think about things. Any other questions? Oh, yes. No. Here. Use the mic.
Thanks, everyone, and congrats again to the team. Thank you for having us. One question, as Ruchiti were talking about the future plans, and Pawanji was also explaining. One is using this data to provide a dashboard and analytical support to the government. And you're sitting on tremendous amounts of data, right? That's so fantastic. And the nurses are now so well trained to use this app well. How are you thinking about using some of this, and if you are already, to use this data to enable her to do her job better? Clinical decision support systems or simple pop-ups, reminders that might help her. And this comes actually as jab hum baat kar rahe the A&M se, it came from A&M or the ASHA. I think it came from the ASHA that one of the pregnant women who had come a few months back, her baby had stopped turning and she was, there was spotting, and we weren't sure what to do. And she was in her 5th month, and you know, all of us were having a conversation with her that, oh, you know, did you try this? Did you try that? But if the A&M at that point, if you think about it, if she had access to, okay, in her last 2 visits, you know, probably her hemoglobin was not coming up, or, you know, there were parameters to watch out for. Could you have referred to her fast? Could you have referred her to a higher facility faster, and so on? So I think a decision support system is probably the next vertical integration pathway as well. And what are your thoughts on that?
So, very important question. Many people have worked on decision support. Yesterday, you also saw Arman was working on that. I mean, NIPI, UNICEF, many other, Japaigo, have all worked on. Different. A lot of work is done in maternal and child health. Naturally, that's a high focus area. We certainly look at guidelines and we try to use those to inform our pop-ups that come up in the app. But there's a huge scope for improvement. There's ways for this to be made more visual. There's ways to have this content given as even training modules and simulations that can be done. I mean, in the Prasav Watch app, there's also a component called Dakshata that is meant to like help with training and gamification in quizzes. So all of that is very, very important. And the better that we can actually engage with the health workers, even when they're not in front of the beneficiary, the better we can actually empower them to take care of the beneficiary. So I think that's one important point. I think another important point is giving them the support when required, because there are, you know, we can list 18 high-risk conditions during pregnancy, 20 high-risk. We can debate over how many high-risk conditions we want, but ultimately each case is unique, right? And yes, ASHAs and ANMs do have a sense of they have an intuition about where something might go wrong, but then the next question is, what do I do with that? You know, you can always refer this beneficiary to the nearby subcenter, but then there's all other kinds of challenges. Will that beneficiary actually go to the subcenter? You know, so that aspect also needs to be addressed, and given more research. I mean, qualitative research needs to happen in terms of how we can better support this referral process to actually complete. We've done some research on this ourselves, and we have realized that social support is one of the big determinants. Whether or not the pregnant woman has her husband there, and he can go with her, actually plays a huge role in her decision making. Even if she is coming from a lower socioeconomic background, she may still complete a referral compared to somebody from the opposite background who may not have a social support in the form of a spouse or the ASHA who can take them. And in some cases, it may require 3, 4, 5 visits before they're finally convinced to actually complete that referral. So I mean, there is a lot of scope for both research and intervention when it comes to completing the referral loop. We talk about, you know, we can certainly track who is being referred and who is high risk, but how many of those referrals are actually being completed? And if you look at our data, I mean, I'm talking about the whole data set. If you take 100 people that we've surveyed, out of that, maybe 10 are high risk. And out of 10, maybe 1 will have an outcome filled from the medical officer level. So there's a huge gap, a huge drop off at both steps, both in terms of identification and in terms of how to manage and how to complete the referral. You know, it was also mentioned yesterday a little bit about telemedicine as maybe something that can bridge the gap here. You know, if there is a specific case that is complex in some way, you know, some 5th month, someone is having spotting, this, that, they can't immediately maybe go to we know that they need to go for a higher level referral, but if there's something that can be done in the interim, okay, let's integrate this with eSanjeevani. If there's 4G bandwidth in that area, they can have a call, WhatsApp call, whatever they need to do in order to get a better sense of what the next step is. And not just that, it doesn't need to be eSanjeevani. I think that also is nice, but not necessary at this point. What is really important, and what we saw today in our field visit, is we had the MOIC and LHV also join us with the ASHA and A&M, is that when that whole team is connected, then that whole team can really work to motivate and get that high-risk beneficiary to the care that she needs. So how do you get those 5 members onto a team is also very important. That can be done through this app, that can be done through WhatsApp groups. I mean, it can be done in different ways, but definitely they need to all have access to the same data. when somebody goes to the medical officer, the ASHA and ANM should get a blink, a notification that, hey, this has been completed, and vice versa, like that was mentioned yesterday. So these types of, like, these pings should be going so that way the whole care team, if you will, is informed and then on the same page. That's really the goal. And that can happen even without needing telemedicine or anything like that necessarily. Sure. Yes.
सबसे पहले तो पिछले 2 दिन में हमने देखा और आज फील्ड विजिट में भी, तो इसके लिए खुशी बेबी की पूरी टीम धन्यवाद की पात्र तो बनती है कि ओवरऑल जितनी चीज़ें हमने देखी बारीकी से, वो भी गवर्नमेंट सिस्टम के साथ और बिना किसी सपोर्ट के, तो काफ़ी कुछ अच्छा था। बट अच्छे को हम और अच्छा बना सकते हैं अगर थोड़ा सा प्रयास करें तो। 2-3 चीज़ें आज हमने देखी थी, उसमें एक तो आपकी जो चिप है वो 512 KB की है। हाँ, आप बताएं।
1 KB 868 बाइट ऑफ स्टोरेज, सिर्फ उतना ही है उसका।
तो आप मुझे थोड़ा सा और जानना चाहेंगे कि उसमें कितनी ANC और टीकाकरण तक वो स्टोर कर पाएगा, कितने टर्म तक?
7 ANC उसके अंदर स्टोर हो जाती है। हमने 7 ANCs का प्रोविज़न रखा है। 7 ANC का डाटा उसके अंदर आ जाता है और बच्चों के फुल इम्यूनाइजेशन और 10 चेकअप का डाटा उसके अंदर हम स्टोर कर लेते हैं।
लेकिन मैंने एक क्वेश्चन क्वेरी किया था वहाँ पे कि भाई अभी एक बच्चा डिलीवर हुआ है, ठीक है, और कोई भी सुपरवाइजरी कैडर वहाँ गया हुआ है, लेकिन वो ये जानना चाहता है कि पिछली जो 4 ANC थी उस महिला की, उसका ANC के समय वेट कितना था। तो ये डेटा देखने का कोई प्रोविज़न मुझे वहाँ दिखा नहीं।
आप उसको स्कैन करते तो आप देख सकते थे उसके अंदर 4 ANC का पिछला डाटा। वो बच्चे का, देखिए मैं इस पे बस क्लेरिफाई करता हूँ। बच्चे का और माँ का दोनों का अलग अलग स्टिकर जो NFC चिप है वो होगा, क्योंकि एक किलोबाइट में हम सिर्फ
नहीं वो तो देखा
7 ANC का डाटा रख सकते हैं या बच्चे के इम्यूनाइजेशन के रिकॉर्ड्स को रख सकते हैं। तो एक मदर के लिए अलग होता है और एक बच्चे के लिए अलग, बाद में जब जन्म हो जाता है उसके बाद अलग दिया जाता है।
हम मदर की बात कर रहे हैं कि बच्चा डिलीवर हो गया,
जी।
उसके बाद देखना चाहते हैं कि उसकी जो पीछे की 4 ANC थी उसमें ANC के दौरान उसका वेट क्या था। ये देखा जाना संभव है क्या कि जब आप वहाँ नहीं हो, सिर्फ ANM है और ऐप पे काम कर रही है, चिप उसके पास है और कोई भी बाहर का स्टाफ वहाँ खड़ा है,
बिना लाइक डिलीवरी आउटकम भले ही फिल हो गया, उससे कोई फर्क नहीं पड़ रहा। अगर स्टिकर अभी भी है, आप स्टिकर में ड्यू फॉर ANC टैब पे जाइए, स्कैन जो NFC का बटन है आप उसको क्लिक करेंगे, आप जितनी भी ANCs के रिकॉर्ड हैं उसको एक्सेस कर सकते हैं बिना हमारी हेल्प के, बिना किसी और के। आप देख पाएंगे कि कितने कौन से ANC में उसका कौन सा रिकॉर्ड है। इसके अलावा मेडिकल ऑफिसर का जो ऑलरेडी हमने जैसे इंटरफेस बनाया है उसके अंदर 2 लाइक इनिशियल जब भी प्रेग्नेंट वुमेन दिखाई देते हैं तो वहाँ हिस्ट्री का एक पेज है। हिस्ट्री के पेज पे हम देख सकते हैं इसके कितने ANCs हुए हैं, उस ANCs के अंदर की सिर्फ वेट नहीं, बाकी के जितने भी इंडिकेटर कलेक्ट हुए थे वो सारी इन्फॉर्मेशन, और अगर कोई डिनाई हुआ था टेस्ट वो भी सारा दिख जाता है। सारा डाटा रिट्राइव हो सकता है हेल्थ वर्कर के पास में। इसके अलावा क्योंकि हमारे पास डैशबोर्ड भी है जो कि डिस्कशन में है, तो डैशबोर्ड पे भी हाँ हम ऑफलाइन डेमो भी करके दिखा सकते हैं।
डेमो तो कार्तिक दिखा देगा, मैं उसमें क्वेश्चन तो बाकी और लोग भी देख पाएंगे।
नहीं डेफिनेटली आप देख सकते हैं उस डाटा को, कभी भी रिट्राइव कर सकते हैं।
आगे हमने एक चीज़ देखी कि बाद में पता लगा कि अभी हाल ही में ट्रेनिंग हुई है ANM की, तो ट्रेनिंग की तो मुझे लगता है पूरे ज़िले में खूब आवश्यकता है।
डेफिनेटली कैपेसिटी बिल्डिंग तो एक ऐसी एक्सरसाइज है जो शायद मुझे लगता है कि हमेशा चलती रहती है, और जब भी कोई नया मॉड्यूल आता है हम लोग उसकी ट्रेनिंग करवाते हैं। जैसा ऑलरेडी हमारा डिस्कशन हुआ था, हमने DHS का ट्रेनिंग दिया था, DHS के बाद ECNFP का जब स्टार्ट हुआ तो उसका ट्रेनिंग दिया था। और क्योंकि लाइक हमारी एक फील्ड टीम जो है वो एक लाइक सिर्फ उदयपुर में काम कर रही है। हमारा मॉडल जो हामिद ने जैसा डिस्कशन किया, मिशन लाइफ सेविंग में हमने क्या मॉडल एक्सेप्ट किया था कि हम स्टेट लेवल से ट्रेनिंग दे रहे थे डिस्ट्रिक्ट लेवल को, देन डिस्ट्रिक्ट लेवल पे जो आइडेंटिफाइड थे वो लोग दे रहे थे ब्लॉक लेवल को, एंड ब्लॉक से PSC। सेम यही मॉडल हम अप्लाई कर सकते हैं।
वो एक परिस्थिति वंश हुआ था, हमें थोड़ा सा उसके लिए कुछ अलग प्लान करना होगा, क्योंकि उदयपुर में हमारी जो कल टीम देख रहे थे इतनी बड़ी टीम लगी हुई है, उसके बाद भी हमें महसूस होता है कि कहीं ना कहीं आवश्यकता है, तो फिर राजस्थान बहुत बड़ा है और
डेफिनेटली आपका जो भी
और
सजेशन है वो तो
कुछ
वेलकम ही है
नए
सर।
जो प्रॉब्लम्स अपने सामने आएंगे वो डेफिनेटली ऐसे आएंगे कि उदयपुर में तो मुझे नहीं लगता कोई सब सेंटर ऐसा होगा जिस पे एनएम नहीं है, लेकिन राजस्थान में कुछ सब सेंटर, पूरी पीएससी आपको ऐसी मिलेगी जहाँ एक भी एनएम नहीं है।
सर आप लोगों
तो
की मदद की ज़रूरत पड़ेगी ट्रेनिंग
एग्जैक्टली
लेने में।
हमारे माइंड में वो पहले से प्लान होना चाहिए
जी
कि
प्लीज़।
हम आगे क्या करने वाले हैं।
हमारी पॉलिसी टीम सर आपके साथ ही बैठती है
हाँ,
और
बिल्कुल,
आपके सजेशंस हमेशा वेलकम है और उनको हम इनकॉर्पोरेट करेंगे।
नहीं डेफिनेटली वो हम करते रहते हैं, लेकिन मुझे जो आज फील्ड में लगा और एक चीज़ जो मुझे थोड़ी सी आज अटपटी लगी, अक्सर मैं फील्ड में देखता भी हूँ, तो वो जब हम जब डेटा को डिजिटली कर रहे हैं तो फिर तो कम से कम एक्यूरेसी आनी चाहिए उसकी। लाइक एक एएनसी जो 20 अक्टूबर को हुई थी और उस समय उस एएनसी में उस महिला का वजन था 43 किलो 700 ग्राम, 43 किलो 100 ग्राम सॉरी, और आज हमने जब उसी एएनसी का वेट किया तो उसका 46 किलो 800 ग्राम वेट था।
Sorry, we need to hold on. There is a speaker who is joining from overseas and
Yeah.
conflicting time zones. So really
Thank you.
sorry. So Pavan ji, maybe you can address it offline, please. So
आपको ये डेटा क्वालिटी का सवाल है। अब मैं तो पहली वाली एनसी के बेट पे ही सवाल उठा रहा हूँ कि उस समय उसने सही डाला था, अब दूसरे एनसी की तो बात अलग है। दैट्स वाई हम बात करते हैं आईवीटी डिवाइस के लिए कि हम ऑटोमेटिक डेटा कैसे भेजो जो रियल डेटा हमारे पास आए। दैट
थैंक यू वेरी मच।
thank you Pavan ji, Vijendra ji, Hamid, Arul and Sarfraz for an informative session. Now, this actually brings us to the final and the most engaging session of the summit. No deliberation would be complete without hearing the views of our partners and peers. I would first like to invite Dr. Sachin Gupta, Senior Advisor, MNCH, USAID India. Please, sir. Thank you.
Good afternoon, everybody. And thank you, Khushi Baby team, for inviting USAID. It's a pleasure, and I'm really delighted to be joining this workshop. So, as Ruchit mentioned, the objective of Khushi Baby and this summit, very honestly, in the beginning, I have also been looking at an opportunity to know more about this platform, since I still had the idea of dependent in my mind when we looked at Khushi Baby some years back. So I was still having an image of dependent and not more than that. So it has been really a great learning for me since yesterday to look at all the elements and from where to where Khushi Baby has come across. And I think the remarks by the previous secretary, Mr. Rohit, and the government officials is a testimony that the platform is really working well, and the government of Rajasthan has now decided to take it over. So there is definitely the amount of work which has gone into this platform is really evident from all the discussions that have happened since yesterday. So there are a couple of points, although I don't have much to talk about. I have learned a lot. The things which we talk about at USAID mainly are actually, when we talk about the digital solutions, are interoperability and integration. So I think this is a solution where we see both of these things in the application. So when we talk about the merits of any digital solution, I think it has to be an open platform. It has to be interoperable so that the existing other solutions can talk to each other, and the integration. So we have been actually struggling with a solution where we can connect the continuum of care. We had the Asman application, which is now the Prasav Watch. We had other solutions where we were tracking the antenatal high-risk pregnancies. We had other solutions where we were working on HBYC platforms, IMNCI platforms, but the integration element was lacking. So I could see that integration, the effort of that integration in this application, and I think that is the thing which actually gives the assurance that now in future we can actually connect the dots with the Ayushman Bharat digital mission also, in terms of whatever digital solution exists, we can work across the continuum of care in the RMNCHA domain, and not only that, across other thematic areas like TB, the NCDs, the health and wellness centers. So whatever is the digital solution present in the country at present, there is a need to integrate and interconnect all these so that they can talk to each other. So I could very well see that in this application. The other point is about the data. We often talk about a lot of data available, and still we keep on collecting more data. So we are actually living in a drip environment, what we say, the data rich and information poor. Now, of course, we could see that whatever data is being collected, it is being used for action. So that is always at the back of our mind, like, okay, whatever we are collecting, we are not just collecting it for data collection sake, but we are taking some decisions out of that data, and we are able to analyze, not only we, but the health system, the existing government system, and we are not creating anything parallel. We are not using our people just to analyze the data and giving something cooked to the government. They should have the capability to analyze that data and take action based on that data. So I think that element is also coming out well in this application. One thing I would suggest is if we can look at the private sector also, because that is another area we keep hearing from the government as well as from the development partners, that a lot of work happens in the public sector. But if we look at even the data of the NFHS 5, if we have 90% of deliveries now happening in the institutions, a lot of them, actually 40 to 45%, happen in the private sector. So where are those ANCs happening? Where is that data going? How can we capture that private sector data into the system? So if something can be, of course, it is easier said than done, and many organizations have also been working on that, but I think this application has the potential to capture that element also. I think when we go to the government, I don't know if you have experienced that or not, there is always a concern about where this data is stored. So whether the server is located here in the country or it's going somewhere outside. So I think, I don't know, like, whether you have had those discussions with the government, and I'm sure, like, if the government is taking that, those things have already been clarified, but that is always a concern we have noticed from the government side about the storage of data. And lastly, I would say that, so I was like talking at, again, one of the digital platforms, and I gave the example of a banking system, like, okay, now all the banking system is digital, and we can do whatever we want, and we sometimes do not know in which bank or what branch our account exists. we can do everything at the click of a button from a mobile phone. So somebody said, no, we are dealing with lives when we work in the health domain. So I think privacy of data, because there is a lot of, I would say, personally identifiable information when we collect data on the health domain. So how to like ensure that privacy of data, and that is one of the reasons I think when we were working with the Asman application with the government, they always insisted on having the paper records also along with the digital data. So I think it will take some time for us to move to the digital platforms completely, and that is what is happening here also in terms of like ANMs or whoever is using the digital application also entering the records at the paper right now. So that is something which is inherent into digital applications when we work with the health systems. But I think the ultimate goal is to have a totally digital application with assurance of privacy of data, no leakage of personally identifiable information. I think I would just end by saying that whenever we develop a digital application, I think now is the time that we need to look at how many existing digital applications we can stop using by developing this one application. Because there is, and we have been hearing since yesterday, there is a proliferation of digital applications. We have had solutions from the government also. Somebody mentioned that we have 40 applications in Rajasthan, and similarly we were talking to other governments. So somebody from Bihar, I think, said that they have more than 50 applications going on. So I think ultimately this looks like a potential solution, which if we try to build on and try to interconnect with the other platforms, can actually go in that direction of having one-stop shop for a digital solution. So again, I mean, congratulations to the whole team, and I think a lot of work has gone into this application. This has come up as a very, I would say, unique kind of a solution, which I have at least seen in past few years of my experience in terms of the integrated solution with different thematic areas coming together. So thank you so much for inviting me here, and congratulations once again to the whole team. Thank you.
Thank you, Dr. Gupta. Our second speaker is Dr. Priya Balasubramaniam Kakad. If we could have her online. So, Priya ji is Director, Center for Sustainable Health Innovations, Singapore. She is a Senior Public Health Scientist, Director, PHFI RNE Universal Health Initiative, and the Urban Health and Innovations Project, PHFI. And she is also the founder of Innovation for USC Asia Africa Collaborative and the Mutual Learning Platform for Mixed Health Systems. And she is a faculty, Center for Culture Centered Evaluation, National University, Singapore, Senior Fellow, Results for Development, Washington, DC. Should we just joining in online? Seems a technical glitch. Just a moment, please. She's with us.
Good afternoon. Am I audible?
Yes, Priyaji, you are. Just a moment, we are just bringing you on screen.
Sure.
Priyaji, if you can please join now.
Yes. Hello. Am I audible now, Hemanji?
Yes, you are, ma'am.
All right. Great. Then I think we can begin. So good afternoon, everybody, and I'd like to thank Hemantji and the Khushi Baby team for giving me this opportunity to present my reflections on what I'm sure has been 2 days of an excellent interchange on Khushi Baby's initiatives in the state of Rajasthan and beyond. So thank you again for this opportunity. I'm actually going to take this conversation from the micro level and the implementation level, which I'm sure a lot of these discussions have been around, to a couple of degrees higher up the altitude to a more macro level. And I come from a research perspective. I'm a public health scientist at the Public Health Foundation of India. We are a public-private think tank based out of Delhi, which have spent a lot of time and our energy in health systems and capacity building over the last many years. So, what does research have to do with digital health ecosystem, and where does the nexus between the two really lie? And I think that is a question that has long been answered. It's a question of the past. One of the things that we have observed with digital tools, interventions, and digital ecosystems is the speed in which they have been implemented across many countries in the world. And between 2020 and 2022, I think COVID has really changed the digital health landscape in many countries. One is because governments were increasingly more aware of the importance of technology actors in their health systems. COVID 19 significantly changed the health sector landscape, and it actually, while it exposed many fault lines in both public and private health systems, it also ensured the role of technology providers being facilitators in augmenting many of those capacity gaps, especially in areas like maternal and child health and NCDs, when the public health systems were often out in the front lines combating COVID and all the challenges that it brought with it. There have been a variety of providers, digital providers, as Dr. Gupta said, both in terms of ownership and relationship to governments, as well as regulatory systems that come from the digital space. There have been renewed interest in approaches for including technology providers in expanding access to affordable health services. So the role of technology actors have started encroaching into the very tenets of universal health coverage and access to health. And there is a need to ensure access at the end of the day to an affordable mix of prevention and curative services, but at the same time reduce the risk of dangerous and exploitative practices. Practices that come from all types of non state actors, including the digital world. But there is often very little clarity on the various mechanisms of engagement between digital actors, the communities, and eventually the state. And that is where research organizations really come in. I'm going to divide this presentation into two. based on my conversation with Hemant. One is I'll talk a little bit about what PHFI does in terms of digital health, why we have made those inroads, and secondly, the more nuanced role of research as an intermediary between digital providers and the state itself and the communities that they serve. So, PHFI has a very broad based context for digital because we work extensively in health systems and health capacity building. A lot of the evidence that we have generated has also resulted in the development of digital health interventions, which have especially come to the fore during COVID. So, just like Khushi Baby, we too have a range of digital platforms and tools that we are now deploying. One is the Myth AI, which is a COVID 19 rapid home screen handheld device. The Digi Sahayam, which is a telemedicine solution for digital health equity, where we are screening NCD diseases in partnership with Star Health Insurance in 6 states. We have Dream H, which is a medical modular logistics system for diverse health conditions, including non communicable as well as infectious diseases. The Swasthya Sahayak, which is a rapid diagnostic point of care technology that we are applying in over 7 states, including Goa as well as Tamil Nadu. And finally, we have a reusable, low cost mask and respirator device, which is also a augment of the COVID-19 pandemic in response to that. So, in addition to many of these kind of digital tools and interventions, we are also experimenting with health access and the role of technology in health access. We have a rapid action lab, which is based out of Hyderabad in Telangana, where we are beginning to test drones to deliver drugs in last mile areas in the state and beyond. Finally, we too, like many other organizations, have partnered extensively with state organizations. The Telangana AI mission is one such mission where we have contributed to the role of artificial intelligence in technologies and the role of ethics in artificial intelligence from a research perspective. So that kind of sums up some of the interventions that PHFI has been engaging in, both in terms of technologies as well as the range of technologies. But this, I think, is a slightly more different hat that we have chosen to wear, and that might be of more greater application to a rapidly scaling intervention like Khushi Baby. So in 2020 and 2021, we actually had a series of dialogues to capture the effect of COVID on global health systems. We were able to have it with the rampant lockdowns in many countries. We were able to take advantage of the fact that many people were working from home, and were able to bring a range of actors from across the globe to really talk about how digital disruption was happening and what was the role of non state actors in responding to COVID and supplementing public health system capacity gaps. So, we had one session on new partnership models, a second session on the governance of the private sector, including digital innovators and mixed health systems. We had a parliamentary dialogue with participants from Asia and Africa. We had a session on the role of evidence in engaging public and private sector stakeholders and new primary health partnership models during COVID and beyond. And really, the objective was to generate fresh ideas on private health service delivery as well as digital technology players can access and engage research partners more effectively, both with governments and public health mechanisms across populations and levels of care. And this was really to create a collaborative platform for shared value creation and alignment. We had over 300 partners, many of them from technology companies, uh, hospitals and diagnostic labs that were using technologies, as well as from governments, multilaterals, funders as well as from the research community themselves. So, what did we see as a result of these dialogues? In addition to, of course, we ourselves being part and parcel of the digital innovation community, we actually saw competing visions of digitally transformed health systems. On one hand, we saw empowered patients, better access to patient centered care, low cost diagnostics, online pharmacies, easy referrals, and platforms like Khushi Baby that were transforming the way maternal and child health were actually being implemented across state platforms. On the other hand, there were criticisms that came from commercialized medicines, digital inequalities and inequities, costly forms of care, a digital divide that was emerging with more and more populations being subject to, say, mobile health or telemedicine. There was a grey divide in India where older citizens and vulnerable populations could not really use the digital technologies that well. There were gaps in digital design. There were also algorithms that reflect interests of producers and diagnostic equipment and pharmaceuticals to use data to increase market share. So, one of the key things that emerged was the role of governance would have to take a bigger precedence in the change process that will eventually influence the direction of development of digital technologies and players. That at the end of the day, while there are many technologies, there is often fragmentation that we see. And this fragmentation has to eventually be integrated into a larger continuum of care with health systems. While Khushi Baby is one platform, there are many platforms like this across states. And at some point in countries, we have to look at negotiating and integrating these platforms for larger continuums of care and for wider populations. So, change and experimentation became a big point. Technology and innovation straddles change and innovation, and scaling. There are many, many technologies that are currently being incubated by many governments, including the government of India. But the problem is, many of those technologies are donor dependent. And once the donor funding dries up, those technologies kind of are become redundant or they are not able to sustain. And so eventually, scale does not become scaling innovations, but scaling of this innovation or a particular innovation. So, scaling of innovations eventually becomes a localized context. And unless we begin to look at it that way, more and more digital technologies are going to flood the market, but not all of them are going to be able to integrate to form a cohesive continuum of care. Regulatory reform has also lagged behind proliferation of digital services, and governments are often playing catching up. Of course, that has now changed with the national health stack and the new digital blueprint that the government of India is rolling out. But this also leads to elements of accountability and trust. And this is where intermediary organizations are increasingly coming into place, a lot like PHFI and other research organizations, who often form an objective buffer between, say, a digital player looking to scale and the government that is trying to make more salient investments in that particular digital player. So, when you look at ecosystems of scale, and I know scale is something that has often been discussed in this 2 day program, there's scaling of innovations, providing care for 2 million 2 million subjects, and so on and so forth. The typical scaling pathway of any technology rests on the ecosystem itself. And there are many actors in this ecosystem. There are research institutions like us, there are incubators and accelerators like DBT and Wellcome Trust. There are governments, both central and state governments. There are private equity firms who are investing in digital innovations. And more important, there are civil society organizations and communities to which these innovations must reach and must eventually integrate. So I think while understanding digitization and digital tools and interventions, one also has to look at the interventions in the ecosystems in which they are embedded in, and all the different actors that are able to influence these ecosystems. So that brings me back to the fundamental question: what does PHFI and an organization like the Public Health Foundation of India have to do with this larger ecosystem? How can we work with organizations like Khushi Baby to take you to the next level? So, one role that is emerging is organizations of research interests is as research intermediaries. So, our role is often as knowledge builders. So, we co create knowledge products, tools, and frameworks to help digital platforms as well as interventions work better with the government. This is through rapid evaluations, quality analysis, as well as equity analysis of digital devices and technologies. There were conversations around equity, I think, even addressed in the session just before this. We serve as connectors. We connect different actors for country led collaboration and capacity development. For example, PHFI manages a wide range of working group and task forces that enable both innovation experts and practitioners from different institutions as well as countries to share learning and collaboration on what's working and what's not. And finally, we play the role of supporters. We provide direct innovation support in response to demand from innovators as well as country level ecosystem actors. So these are the emerging roles that research organizations themselves see themselves evolving as we begin to look at how digital interventions, tools, and ecosystems are changing the health system landscape. So finally, I'll end with two slides. There are really no best practice models for countries to replicate because digital transformation often disrupts existing arrangements. So, governance arrangements need to adapt to local contexts. And in some ways, Khushi Baby is already doing that. You are working very closely with Rajasthan. And perhaps your next, your next mode would be working with other states as well. Stakeholders with different perspectives need to build a common understanding of the structure of the health system and challenges to be addressed. And that is really very important. Third is who owns data and how much do we need? There are a lot of digital players collecting reams and reams of data. But how much of the data do we actually need? How much of it can be understood by those who are using some of these digital devices like ASHAs, like ANMs? And how much of that data really reflects back in terms of decision making? How much can it help a state to better improve health systems capacities within that state? And what kind of mechanisms are eventually needed to support local learning and mutual learning, not only between countries, but between states? So I'll finally end with more questions because as a researcher, that's what we do. We ask questions as much as trying to find solutions for these questions. And these are some of the broader questions around research and learning, which I think would impact relationships between research entrepreneurs like ourselves and digital entrepreneurs like yourselves and the state. And some of the emerging questions are: how can governments influence the direction of innovation? And what are the relative roles of local as well as international companies? How can contracts between government health services and technology companies ensure accountability for innovation and change? Because this is going to be something for the future. More and more state governments are looking to engage digital providers, but what are those rules of engagement? And how do we begin to understand them? How is digital transformation influencing access to services by different social and economic groups? So, how do we begin to address the digital divide? And what is the digital divide? And to what extent are different stakeholders influencing the development of treatment algorithms? Artificial intelligence is here to stay. It will probably influence every aspect of digital care, especially as we move towards more advanced care of digital telemedicine and other areas. How can we bring in an element of equity and ethics to artificial intelligence? And how do we balance against things like algorithmic biases, for example? And finally, what structure of the global digital industry is there, and how does this influence the direction of innovation and government governance arrangements? So there are wider discussions among WHO and other multilateral organizations on stewardship of digital technologies, and that is going to have a large bearing on how countries channelize and deploy digital interventions as well as platforms for better care. I'll finally end with a couple of reports that PHFI has put out as part of our mutual learning series. You can access them at our at the following link, www.innovationforuhc.com, and look forward to continuing this partnership. And thank you very much for giving me this time. Thank you.
Thank you, Priyaji. Our next speaker is Dr. Yashpal Jain, State Head Rajasthan, Japaigo, India. Please.
Thank you for having me here. So I'll not say that we are working with Khushi Baby in 2 projects. So we are partners. These 2 projects are related with antenatal strengthening and use of technology. Prasav Watch, linking of Khushi Baby application with Prasav Watch and making them interoperable is part of that antenatal risk stratification where we are working. So one thing that I would like to say about Khushi Baby is that their willingness to adapt. You know, we started working in 2018, and the immediate need for us under one of our project was to develop AMO module. And when I say AMO module, why we need someone was with us in Badolia sub-center, and there are high-risk pregnancy which are being identified, and because of that intervention, high-risk pregnancy identification improved from 2 to 11%. और देन वी रियलाइज़ कि इन महिलाओं को हम PSC या CSC पे कैसे लेके जाएं और हम इनका फॉलोअप कैसे इंश्योर करें, एंड दैट वाज द नीड ऑफ आर फॉर आर प्रोजेक्ट. एंड खुशी बेबी, you know, they really came forward, and within 3 to 4 months time they supported us in developing a cut short version of AMO app. So because of that, you know, we were able to track and link the high risk pregnancy to medical officer. There are so many things which has already been talked, and as a partner, what we feel that we should start thinking about, what is the use of clinical decision support system. Decision support is already inbuilt. एप्लीकेशन में यदि आप लोग देखेंगे ANM ऐप में या प्रसव वॉच में या किसी में भी, decision support is already there, but how ANM is using, whether they are using it or not, and if they are not using it, why they are not using it. The second thing that I strongly feel and believe that every solution should be developed from users perspective. और वो जो कहते हैं ना, what is in it for me, यदि आप मेरे को कुछ चीज़ बोलेंगे तो मैं सबसे पहले पूछूंगा मेरे को इससे क्या फ़ायदा होने वाला है. And for ANM application again, we need to start thinking. I was talking to, not I was, we were talking to ANM, and then she said ये RCH register तो कभी अलग नहीं हो सकता. And then I said कि ये क्यों नहीं हो सकता? It can be removed and it should be removed. यदि हम वास्तव में इस डिजिटल इंटरवेंशन को, you know, we want to take it to next level. As of now we are dealing with 187 or 200 ANMs, but in Rajasthan there are 15,000 ANMs. और यदि हमें इन सबको अलग करना है, के साथ काम करना है, then definitely we need to start thinking about how to remove that RCH register, how to make their work, you know, efficient and easy, so they can use digital application to their full extent. And the third thing that we feel, I saw a pregnant woman that was 32 kg. She was 4th month pregnant. That was her second child. So though we have bucket for high risk pregnancy, but you know, somehow we need to develop a separate bucket for the severely high risk pregnancy, because moderate anemia is everywhere. So every woman is falling into that high risk category. But these kind of women which are, you know, as a partner we need to think about how to make that workflow in the application and how to make it visible to medical officer who is supposed to provide quality services to the ANM. And the last point, we are talking about equity. Dr. Aparna was here from Arman. So equity again, you know, we need to work to ensure equity in our intervention. As of now, what is happening, we are trying to provide everything to everyone. And on long run, I don't think it is going to work. These 11% high risk pregnant women, they require some kind of special care. And as a team, we need to really think about how to ensure that women are getting equitable access to care, which will help them to get a better and maternal and neonatal outcome. Yeah, this is the last one, sure. So the time spent on any client, that is something that again we need to measure, and as a team we need to think about how we can reduce this time taken for any client flow. Today morning only we were looking at the continuum data, and then I realized that if we establish that continuum, that there is time saving of like 4 to 5 minutes of each and every labor room staff. I am talking about labor room staff. क्यों? क्योंकि आपके पास जो भी डेमोग्राफिक डिटेल्स हैं, they'll automatically get auto-populated in Prasad Watch application. So those 4 to 5 minutes can be used to provide quality services to the client coming into the labor room. So thank you so much for having such a wonderful experience, wonderful workshop. I really learned so many things, and I'm looking forward to take all these learnings to in our next level of partnership. Thank you.
Thank you, Dr. Jain. Our next speaker is Dr. Pradeep Chaudhary, State Head, Rajasthan, NIPI. Please.
Humanji, am I the last speaker? As a last speaker in the last session on the last day of the workshop, so what do I say? And what is my objective here? At the very outset, when Ruchit said yesterday that why are we having this stakeholder summit, my objective is to promote Khushi Baby. And I am selfish, although I am selfish, but I am honest. And I really like that phrase. So what are we all here for? We are all here to promote good work. We are all here to support the people who are doing good work. And we are here to promote people who are doing something which would benefit the community in whatever way it can. So, जब हम खुशी बेबी को, मैं जो अपनी बात बहुत ही संक्षेप में कहने जा रहा हूँ कि खुशी बेबी के सफ़र को मैंने दूर से देखा है, कभी दूर से कभी पास से, और उसमें मेरी क्या ऑब्जर्वेशंस रही हैं उन्हीं के बारे में मैं यहाँ बात करने वाला हूँ। खुशी बेबी ने जो सफ़र, जो रास्ता चुना, वो एक नया रास्ता है। नया रास्ता क्योंकि राजस्थान के अंदर हम देखते हैं कि इंटीग्रेशन की बात, डिजिटलाइजेशन की बात, नई नई चीज़ों की बात बहुत से लोग अलग अलग मंचों पे अलग अलग जगह कहते हैं, लेकिन किसी ने वो एक सिंसियर प्रयास नहीं किया और वो कोशिश नहीं की, या तो वो उतना मादा नहीं था, या उतना मौका नहीं था, अवसर नहीं था, या क्षमता नहीं थी, लेकिन वो काम कभी बहुत ज़्यादा आगे बढ़ा नहीं। तो खुशी बेबी ने ये जो सफ़र शुरू किया और ये जो रास्ता चुना, ये बहुत ही अहम, और क्यों अहम है हम पिछले 2 दिन से देख रहे हैं, उस बात को वापस दोहराने की आवश्यकता नहीं। और जब आप कोई ऐसा नया रास्ता चुनते हैं तो उस रास्ते में जाहिर है कि बहुत से खड्डे भी आते हैं, बहुत से छायादार पेड़ भी आते हैं, बहुत से ऐसे हमसफ़र आते हैं जिनको आप साथ लेके चलना चाहते हैं, और बहुत से चैलेंजेस भी उस रास्ते में आते हैं। तो खुशी बेबी का जो सफ़र है वो कुछ इसी तरह का सफ़र है, लेकिन हम आशान्वित हैं कि जो मंजिल वो तय करना चाहते हैं हम सब उसमें मदद करेंगे, सरकार भी उनकी मदद करेगी, और जो उनके वेल विशर्स हैं वो सभी इस काम में उनकी मदद करेंगे। बहुत सी अच्छी चीज़ें जो खुशी बेबी के अंदर हमने देखी हैं कि जो ये जिस सफ़र पे निकले हैं, एक बात तो हर व्यक्ति कहता है कि टीम बहुत अच्छी है। हर व्यक्ति ये बात कहता है कि टीम बहुत अच्छी है, काम जो कर रहे हैं वो भी बहुत अच्छा कर रहे हैं, डेडिकेटेड टीम है, बहुत अच्छा काम कर रहे हैं। और अगर टीम अच्छी हो, मकसद हमारा अच्छा हो, तो कामयाबी क्यों ना मिलेगी? कामयाबी खुद आपके कदम चूमेगी, और यही हमारी उम्मीद है और यही हमारी आशा है कि आपको जो कामयाबी है वो पूरी तरह से मिले। बहुत सी हमारे ऑर्गेनाइजेशंस हैं जो कि अपने अपने एक साइलोज में काम करते हैं। मैं 2005 से NHM के साथ जुड़ा था। आई वॉज ऑल्सो द स्टेट प्रोग्राम मैनेजर फॉर NHM। और जब होता साहब 2005 में बात करते थे, आवर यूनियन हेल्थ सेक्रेटरी देन, ही यूज्ड टू से दैट नाउ is the time for integration. 2005, 12th April 2005, if you read the speech, he says, now is the time for integration. The time has gone when we continue to work in silos and verticals and this and that. और अभी लगभग 17 साल के बाद भी हम देखते हैं कि आज भी जो हम बात करते हैं, पिछले 2 दिन से बात कर रहे हैं, एक बड़ी हमारी बात जो है वो इंटीग्रेशन पे है। चाहे वो हमारे प्रोग्राम्स का डिजिटल इंटीग्रेशन हो, हर वर्टिकल प्रोग्राम आज भी अपने उसमें खड़ा हुआ है। वो इंटीग्रेशन एक बहुत बड़ा चैलेंज है, और इन तमाम चीज़ों को इंटीग्रेट करना, क्योंकि एक तरफ तो जो प्रोग्राम, क्योंकि इस समय जो हम देखते आ रहे हैं कि बहुत रस्साकशी चलती है। एक तरफ प्रोग्राम डिविजन्स हैं, उन्हें अपना सारा डेटा चाहिए। जो भी हम ऐप बनाएं, जो भी हम सॉफ्टवेयर बनाएं, तो एक तरफ हमारे प्रोग्राम डिविजन्स को उसमें पूरा सारा डेटा चाहिए। What Gupta ji said कि डेटा रिच एंड इन्फॉर्मेशन पुअर, तो हमें डेटा तो बहुत सारा चाहिए। कितना यूज़ होता है, बार बार हमारे अनेक वक्ता आ रहे हैं वो ये कह रहे हैं कि कितना हम उसको यूज़ कर पाते हैं वो नहीं, लेकिन उससे हमें लगाव है क्योंकि हमारी प्रोग्राम्स की रिक्वायरमेंट है, तो हमें डेटा बहुत चाहिए। और दूसरी तरफ हमारे लिए एक बड़ा चैलेंज ये रहता है कि हम जो भी चीज़ बनाएं वो ग्रास रूट लेवल, सबसे नीचे के तबके के जो वर्कर्स हैं उनके लिए कितना सिंप्लीफाइड हो, ताकि वो उसको आसानी से उसको इस्तेमाल कर सकें। तो इस रस्साकशी को किस तरह से आप मैनेज कर रहे हैं और किस तरह से इन तमाम चैलेंजेस को नेविगेट कर रहे हैं, इसके लिए भी मैं आपको मुबारकबाद देता हूं कि ये एक बहुत बड़ा चैलेंज है और इसका कोई आसान हल नहीं है, ये हम जानते हैं। किस तरह से इसको एक सीमित स्तर के ऊपर ला के शुरू किया जाए, ताकि, क्योंकि इसका कभी परफेक्शन, इस इंटीग्रेशन में कभी परफेक्शन नहीं आ सकता, क्योंकि हर व्यक्ति जो है उसको बहुत लगाव है अपनी अपनी चीज़ों से, वो उस पर अड़ा रहेगा और कोई सॉल्यूशन उसका हमें निकालना ही पड़ेगा। और मुझे लगता है कि जो स्टेक होल्डर्स की आपकी जो समिट्स हैं उनके अंदर एक मिनिमम एक्सेप्टेबल लेवल जो है उसके ऊपर हमें कहीं जाना पड़ेगा। खुद हमारे राज्य के अंदर इस समय ऐसी सब चीज़ों को आगे बढ़ावा देने का इंस्टीट्यूशनल मैकेनिज़्म बहुत कमज़ोर है। किस तरह से इनोवेशंस को लाया जाए, कौन से इनोवेशंस आएँ, कौन उनके ऊपर निर्णय लेगा, किस तरह से उसके ऊपर एक सामंजस्य, एक कंसेंसस उसके ऊपर लाया जाए। सो देयर इज़ स्टिल अ ग्रेट नीड फॉर हैविंग एन इंस्टीट्यूशनल मैकेनिज्म विद द गवर्नमेंट to institutionalize this whole process of bringing innovations, whether they are digital or otherwise. So that is also a very important thing. The frequent changes in bureaucracy. The frequent changes in bureaucracy which sometimes bring everything to a standstill, which sometimes slow the pace. All these problems, they are cropping up because these mechanisms have not been institutionalized. अगर हम इनको institutionalize कर दें, इनका एक संस्थागत ढांचा हमारे यहाँ डायरेक्टरेट्स के अंदर बन जाए, तो ये जो तमाम तरह की समस्याएं हैं ये इनका हल होगा। और न केवल खुशी पे भी, बल्कि जो तमाम NGOs, डेवलपमेंट पार्टनर्स, रिसर्चर्स, उन सब के लिए एक प्लेटफॉर्म मिलेगा कि हम उस प्लेटफॉर्म के ऊपर जा सकते हैं, अपनी चीज़ों को रख सकते हैं। फिर उसके बाद वो कितनी फाइनेंशियली वायबल हैं, कितनी सस्टेनेबल हैं, उन चीज़ों के ऊपर चर्चा हो। द गुड थिंग अबाउट खुशी बेबी इज़ दे आर ओपन टू इट, दे आर ओपन टू क्रिटिसिज्म, दे आर ओपन टू गेटिंग द फीडबैक, विच द गवर्नमेंट समटाइम्स इज़ नॉट सो। तो हमें एक ऐसा मैकेनिज़्म हमारे को डेवलप करना है जिसमें हम सब लोगों को ध्यान कोशिश करनी है. Representatives of government are few, but they will be getting the report and the proceedings of this workshop. So I think one thing, if it comes out well of this stakeholder summit, is that an institutional mechanism should be created with the government for all innovations, including digital innovations, how people can bring new things, how they can be vetted, how the sustainability, financial viability and other things can be tested, and so on. So I had many things to say, but being the last speaker and this being the last session, I would just stop here, and I wish all success to Khushi Baby team and all the people who have come here. So thank you so much for inviting me.
Thank you, Dr. Chaudhary. I'll now request Ruchit, if you could please come on stage and propose a vote of thanks. Thank you.
All right. Last but certainly not least. So really thank you for sharing those comments. Thank you. So I won't take more time. 5 minutes. I liked one word that you said, suffer. Like both lamba suffer hai, right? And it is a process. It's not a destination. But hum ye bhi chahta hai ki we make progress on this journey. Like I hate it that I have to always ask for forgiveness from the A&M or Asha when I visit. Maafi mangna padta hai that you still have to use your paper register. Right? मैं माफ़ी नहीं मांगना चाहता हूँ. Why do I have to keep doing this year after year after? One more year, maybe the government will approve it. One more year after, the government will approve it. But they have been very patient. More patient than we could have even expected them to be, right? And now it's time for us, development partners, in partnership with the government, in partnership with the central government that is helping support this initiative financially, to put in, like you said, the institutional mechanism, the policy mechanisms in place, so that this becomes the actual standard process, so that we do not need to have the RCH register anymore. No matter how useful it has been in the past, it is something that we don't want to burden the healthcare workers with. So I think we all have a common vision, and it's taking a lot of time, and we have to be patient and see small steps as we make them. So we have to remain optimistic. And I think that I was also very encouraged by the reflections of various different state officials on the first day of the event, that they themselves were bringing up points, bringing up suggestions, bringing up the importance that we need to work together, that this digital technology needs to be pushed. 5 years ago, maybe they may have said something differently. They may have said that, is this even required? There has been a shift in their mindset. There has been a shift at the local level. I mean, Udaipur itself has shown you how much it's been willing to experiment, how diverse Udaipur itself is, and how much learnings it can produce. Rajasthan has always been trying to push the frontier when it comes to digital. And now even at the government of India level, we also know that with Ayushman Bharat, there's a huge push in this direction. So I think the only way, like I said, we can really go forward is if we go together. We try to take a common base and try to build off of that, rather than trying to, basically build the same thing or replicate each other's work. That's not what we're here for. And that requires partnership. That requires real access, sharing of data, sharing of technology, sharing of knowledge. While we have certain in-house expertise, where we have a good field understanding, we have a good ability to build technology solutions that now can be scaled, and we have a burgeoning even data science arm, we still need the public health expertise from organizations that have been doing this in the field for much longer than we have. We still need to listen to the voices that are on the ground and to the policymakers that are dealing with other kinds of challenges. So with that note, I want to kind of recognize the partners. And you may not have realized this. I didn't realize this, in fact, until I went through the agenda, how many partners have been able to join us, mostly in person or either virtually. I'd like to read out their names in non-alphabetical random order that I just got. So this is not in any order of importance, but I'm just going to go ahead. JAPIGO, USAID, NIPI, WHO, PSI, Plan India, UNFPA, UNDP, CCAMP, PATH, GH Labs, BMGF, Gavi, Wadia Hospitals, UN World Food Program, Save the Children, Center for Microfinance, Tata Trust, Arman, PHFI, Seva Mandir, SRKPS, IIM Udaipur, UBS Optimus, Sattva, Dasra, and I might have left out some names. Of course, I should not forget the government of Rajasthan, government of Udaipur that have been here. All of you, and I'm sorry again if I missed anyone, I probably did, are here. There's like 20 different partners who are potential collaborators, and we want to actually come up with game plans of how we can work together. So our homework from this meeting, we have a few different things that we need to do. One was mentioned by the state program manager, Dr. Lokesh, yesterday, is that we need to put this into a concept note so that way it can go through the innovation mechanism that NIPI has set up. It can be proposed and taken up through that channel. That's one. Two, we would like to have specific game plans and roadmaps with each of the partners that are here to see how we can at least have some kind of bilateral collaboration, if not, if it makes sense for some kind of multilateral collaboration where it is appropriate. And we hope that we can at least start that conversation in the next week and then use that to move forward. We don't want this to just be a workshop. You saw what we did, great, okay, now back to wherever you have to go to. We want this to actually lead to a next step. So we will reach out, and we hope that you will reconnect with us. You are always welcome back here to Udaipur to see our field in more depth. I know running through, I don't know, you saw the app is like we printed it out. It's 300 pages of screens in a booklet. There's no way that we could have shown you all of that work in 1 hour that we tried to do yesterday. The dashboard, thousands of lines of code. There's no way we could have shown you the full extent of what goes into that yesterday. So definitely we are trying to spark your curiosity. Hopefully you got a fair idea of what kind of work we're doing, what our team is capable of doing, and what we can do when we partner together. Really, that's the most important thing. So with that, I'd like to again extend a vote of thanks to all of you, especially special vote of thanks for all those that have stayed here for day 2 and got the special privilege of meeting our Ashas and A&Ms in the field. I think that's really wonderful and speaks to your commitment as well. And we look forward to having our next workshop, summit, and being a part of the next gatherings that our partners will also be hosting in the coming time. So thank you all so much. We look forward to collaborating. And again, thank you for coming.
So, thank you, Ruchit. As the summit concludes, we would request you to, the tea has been organized outside, so maybe we can just have a tea, please. Thank you.